I recently presented the comparative effectiveness of Ibrutinib flexible dosing treatment strategies on the time to next treatment in a large community-based claims database using a target trial emulation study at the ASH 2023 meeting. We know that Ibrutinib is a once-a-day BTK inhibitor approved for treatment in CLL, SLL, and dosing flexibility with Ibrutinib can prevent recurrence or worsening of adverse events while maintaining treatment efficacy. There is some data available for dose adjustments showing that if you adjust doses, it does not impact efficacy and it may help with toxicity management. But there's an unmet need for a comparison of using statistically valid methods for dose adjustment strategies versus full dose for Ibrutinib. So ideally, a randomized clinical trial is the best way to compare these two different strategies: a full dose strategy versus dose reduction strategy. But in the real world setting, because patients may start with a full dose and then go down to a lower dose down the road, it can introduce certain biases like immortal time bias. And in order to overcome this immortal time bias, we use this target trial emulation approach, where you design a hypothetical, randomized study, and then you emulate the real world results onto this and try to overcome the immortal time bias by process of cloning and censoring. And then you can do a statistically valid analysis called time-varying inverse probability of censoring weights to account for the differences between the arms. And then what our main endpoint for the study was the time to next treatment, which is a very valid endpoint, looking sort of mimicking a progression-free survival endpoint in the real world. So we looked at the time to next treatment of Ibrutinib at a full dose of 420 milligrams compared to Ibrutinib, which is 420 milligrams daily, followed by a dose reduction strategy. And we used different time periods where the dose could be reduced, but primarily looked at 3 to 12 months. So that was those were the two comparator arms, and this was a very large analysis. 3,342 patients were included in this analysis, including 2,640 patients, so nearly 80% of patients who had high cardiovascular risk. And these patients came from many different parts in the U.S. The mean age was 67. And so one thing we noted was that of the 608 patients who were treated with first-line Ibrutinib with dose adjustments, only 46% had dose adjustments between the 3 to 12 months post-index, and the predicted time to next treatment comparing Ibrutinib dose adjustment strategy compared to full dose, there was no difference. So both those, were very similar, and therefore, and this was also true in those patients who had high cardiovascular risk. So, this was very, good to see that even if you dose reduce, which is very likely for side effects, you are still able to get, equal benefit as full dose. And so this was, this can really have practice implications, and it would suggest that patients should be reduced, the providers should be able to reduce the doses for patients who have adverse events and not compromise efficacy. At the same time, it may allow them to, manage their side effects a little bit better and continue with their treatment. There are some limitations to these real-world analysis, which may include that the reason for dose modification cannot be ascertained from this. We also looked at did a washout period prior to starting the treatment index date, and to ensure that the patients did not receive any other cancer therapy during that time, but they could have still received some treatment prior to those. And then, we capture data from only the insured U.S. population, and not necessarily, uninsured patients or underserved populations. So it may not be generalizable to all. But to conclude, this is the first real-world analysis which utilizes this target trial emulation framework to assess the comparative effectiveness of flexible dosing. And what it showed is that there was, only a small number of patients, first of all, needed to dose reduce. And then secondly, like the dose reduction strategy did not affect the time to next treatment. And this suggests that, patients can dose reduce and still continue to benefit from Ibrutinib.